Welcome back. In this second part of the 4 common theories of communication and behavior, we'll focus on diffusion of innovations and fear or risk management, sometimes called the extended parallel process model. The diffusion of innovations, or diffusion theory, is a narrative about interaction, information sharing, and decision-making within a social network. Some of the basic assumptions of diffusion theory are that people choose to act based on how they perceive the action in the context of their daily lives, what they see other people doing, and how people talk about and share information about that action within their community, within their family, within peer networks, and so on. New ideas often come from opinion leaders or from someone outside the community, but they are rejected or adopted within social networks of people who share common interests and values, like the people in your neighborhood or in your workplace. One of the most famous studies of the diffusion of innovations was done in South Korea in the 1970s. This picture on your slide is the picture of Oryu-Lee, one of the villages where this study was conducted. And in this village, you see the houses of the families arranged around the village, and you see in red circled the house of Mrs. Chung. Now, Mrs. Chung was an older woman. She was an outsider to this village. She had grown up and lived in another village for many years, but her husband had died, and after that happened, she moved to Oryu-Lee. Mrs. Chung became the leader of a mother's club in Oryu-Lee. She organized the women to improve their homes, to improve their quality of their kitchens, and she introduced other ideas to them, like the practice of family planning. Now, Mrs. Chung represents one of the key concepts in the diffusion of innovations, which is called the strength of weak ties. Because Mrs. Chung was an outsider, it was a little bit easier for her to introduce new ideas into the village. In other words, while people in a village may have strong ties to each other, they know each other well, they do things together, they go to the market, and so on, an outsider may be a very powerful influence in the community because they have access to information from outside the community. Here's another picture of the same village of Oryu-Lee. It looks a bit different, doesn't it? The circles, the small circles with the numbers in them in this picture, represent the women who lived in the houses you saw on the previous slide. Researchers asked each of those women who they talked to in the village about family planning. And for each woman who was mentioned, they would draw a line. So, for example, can you find Mrs. 44 in this picture? Yeah, Mrs. 44 is in the upper center of the picture. There are 5 lines going from Mrs. 44 to other women in the village, meaning that Mrs. 44 reported talking to 4 other women in the community about family planning. Can you find Mrs. 21? Mrs. 21 is in the lower center of the diagram, and you can see that she has only 1 line going from her up to Mrs. 4 on the right top of the sociogram. That indicates that Mrs. 21 reported talking to only 1 other person in the village about family planning. Now, can you find Mrs. Chung? Mrs. Chung, number 13, is marked in the red circle on the far right of the diagram. And you can see that Mrs. Chung reported talking to a lot of other women in the village. This illustrates another important principle of diffusion of innovations. Mrs. Chung is what we call an opinion leader. An opinion leader is someone that other people in the community or in the neighborhood or in the workplace turn to for advice, someone they trust, someone they talk to, someone they approach for information when they have a question. A third feature of the diffusion of innovations that can be very helpful in understanding audience behaviors and designing behavior change communication programs is how people perceive the action or the innovation that we are trying to promote. Does it offer some advantage over the current behavior? Is the new behavior compatible with what you currently do? Is it compatible with your beliefs and with your values? Is the new behavior difficult to perform, or is it easy? How complex is it? Can it be tried without too much risk before making a decision? And finally, are there opportunities to see what happens to other people who adopt this behavior? These perceptions are called relative advantage, compatibility, complexity, trialability, and observability. And you might notice that some of these concepts are similar to things we heard about in social learning. Observability, for example, refers to opportunities to see what others do. Remember, in social learning, people learned by watching what others did and what happened to them. So you can see that these theories sometimes overlap a little bit, but they also have their own unique features. So diffusion theory points to slightly different things to think about. How does the audience perceive the new behavior or the new product we are offering? Those 5 characteristics that we just talked about. Who are the important people in the community or in the media, perhaps, that people trust and listen to or turn to for advice? And how can we create messages to change how people think about the behavior in order to make it appear more beneficial or easier to do, or to show what happens when you do it? So what would the care-seeking narrative be from a diffusion perspective? How would we describe the young woman in Tanzania dealing with malaria and a daughter who was feverish? What story would you tell? Well, we might focus on how she perceives this new behavior of testing her child for fever. Is it convenient? Is it compatible? Does it have an advantage over what she has been doing and the way that she's been treating her daughter in the past? And where does she get information about this? Does it come from her neighbors? Does it come from her family? Does it come from the media? What are her sources of communication, sources of information within the neighborhood or within her village? And who else is doing that behavior? Who else is taking their children for malaria testing and treating them? And what's happening to them? Can she see that their children are healthier if they've taken them to the clinic for a test and given them the right medicine they need in order to prevent malarial fever? And how are power and access distributed in the community? Who has information? Who are the opinion leaders? And who is influential? Who influences the health behaviors of women and families in the community? All of these things are unique to the diffusion perspective. If we see that some of these issues are important in a particular community, we may think about using diffusion to tell that narrative. Now, the last theory I'd like to talk about is risk or threat management theory. This theory actually goes by a number of different names. Some people call it extended parallel processing because it refers to the interaction between cognition and emotion, between rationality and emotion in decision-making. Other people refer to a similar theory, the risk perception attitude framework, but all of them share some common features. Some of the basic assumptions of this approach are that fear can be motivating or incapacitating. It can be positive or negative in terms of decision-making. Fear usually motivates people to act, but too much fear can be a bad thing. Some of the early research on fear appeal messages showed that some messages were so frightening that people tried to avoid even thinking about the issue and ignored the campaign messages. For example, some early studies promoting dental health or toothbrushing showed people horrible pictures of gum disease with the intention of scaring them about gum disease and motivating them to take up daily toothbrushing as a solution. But some people found those pictures so repulsive, so horrible, that they refused to look at them and wouldn't even think about this issue because they didn't want to experience that fear and revulsion. So there are 2 components to this model, 2 aspects of it. One is the fear or threat component, which refers to the emotional reaction that people have. It's usually the emotion that determines motivation. And threat or fear has 2 components to it itself. One is severity. This refers to how serious people believe the threat to be. In the case of malaria, how serious do people think malarial disease is? Can it cause death or not? And a second part of threat is susceptibility, which refers to the belief that the disease or the threat can actually happen to you. So while you may think that malaria is a serious disease, you may not think that you yourself are at risk of contracting malaria. Together, severity and susceptibility define how threat is perceived. The second part of this model is efficacy, or confidence in your ability to control or manage the threat or the risk or the fear that you feel in the face of a threat. Efficacy is the cognitive or rational part of this model in comparison to the emotional part that threat represents. Efficacy, like threat, has several components or several aspects. One is response efficacy, which refers to a perception that a proposed solution will actually control the threat. For example, do you believe that bed nets can prevent malaria transmission? The second part of efficacy is self-efficacy, which refers to the perception that you, yourself, can perform the action in order to control the threat. So, for example, self-efficacy might refer to whether you think it's possible to use a bed net consistently in order to prevent malaria. The third part of efficacy refers to barriers, a perception of what might stand in your way that would prevent you from practicing the behavior in order to reduce the threat. So how does this theory help us to develop a communication strategy? One of the nice things about this perspective, risk management or EPPM, is that it can help us to segment our audience into different groups who might require a different kind of narrative. Efficacy perceptions can be divided into high or low. For example, some people might feel very confident that they can control the threat posed by malaria, while other people may feel very little confidence in their ability to control the threat of malaria. Threat perceptions can be divided into high and low. Some people might feel highly threatened by malaria, while others might not feel threatened at all. So this 2x2 chart shows 4 very different kinds of audiences for malaria messaging. On the one hand, you have some people who feel threatened by malaria and also feel confident that they can do something to prevent that threat. We might call these people engaged. These are people who think that malaria might happen and also know that they can protect themselves if it occurs. A second group we might call confident but not engaged. These are people who feel confident that they can control the threat of malaria, but don't think that the threat is very real or very high. These are people who believe they can protect themselves from malaria, but don't think it will happen. Let's compare these to the people in the second column on the right. Here you have people who might be concerned about malaria because they perceive the threat, but don't think they can do anything to protect themselves. And the fourth group is people who don't think malaria will happen and don't think they could do anything about it anyway. We might call these people disengaged. Each of these 4 groups might require a different kind of messaging strategy. The engaged people who are already confident and perceive the threat might just need cues to action to encourage them to seek malaria treatment or to use a bed net. The confident people might need education about realistic risk perception. We may need to convince them that malaria does in fact pose a threat to their community and to themselves. The concerned people who perceive the threat but don't know what to do about it could be educated about measures that they can take to prevent malaria or to treat it if they fall sick. And the disengaged group that neither perceives threat nor has confidence to deal with it might need both education about the realistic risk that they face, and they would need education about what to do in order to address that risk. So in some situations, we might want to consider using the risk perception or risk management, fear management framework for our programs. We would use this perhaps to help us identify how audiences think of the health issue. Do they consider it serious? Do they actually feel threatened? Are they fearful? Or are they unconcerned? And we can use this framework to help us identify what people think the solutions might be, how they can avoid the danger, and whether those solutions can actually be achieved. And we might use this framework to help identify messages that change perceptions of threat and efficacy. Can we increase how serious someone regards the threat of malaria to be? Can we help them understand whether they actually are at risk or susceptible to malaria? Can we increase their knowledge of what to do about malaria to prevent it or to treat it? And can we show them how others have responded and what the consequences, what the outcomes of those behaviors might be? Healthier children, fewer cases of malaria, and so on. And we can show them how others have overcome barriers to the behavior. So what would your care-seeking narrative be from this perspective? How would you tell the story of the young woman in Tanzania who wanted to protect her daughter from malaria? In this case, you might focus your narrative on how serious the young woman perceives the threat of malaria to be. Can malaria fever be fatal? And does she think that her own daughter can fall sick? We might also focus that story on what she thinks can be done about it. Getting her child tested, getting herself tested during pregnancy, using a bed net to prevent mosquito bites in the first place. And we might also focus on whether she thinks that she is able to achieve those behaviors, to practice good preventive malaria behavior, or seek treatment at the appropriate time. So that concludes the summary of our 4 theories. I think it's important for you to understand that all of these theories are simply descriptions of how people behave. So if we think of theories as stories, we can use them creatively to develop strategies and messages for our programs. If our messages, our theories, are based on the evidence, are based on what people in the communities actually do, then the messages that we produce should reflect the story in that community, the story of how people decide which behaviors to practice and what stands in their way or makes it easier for them to do so. The better your message is matched to a theory, the more likely it is that your messages will have the outcomes that you desire. So in summary, let me quote Kurt Lewin from 1954. Kurt Lewin was one of the giants of the social psychology of communication, and he said, "There is nothing as practical as a good theory." So the theories that I've been describing to you in this lecture are really just tools for thinking about what causes the behaviors that you want to influence. Why do people act the way they do? What factors are most likely to encourage or facilitate the behaviors that your program wants to encourage? Is there anything that you've forgotten to consider? Any explanation, any motivation, any fear or concern that your audience might have that would prevent them from doing what you would like them to do? And how can your program use communication to overcome barriers, to help people take protective action in the face of challenges or in the face of poor resources or resistance from their friends or family? So after a short break, I'd like to come back and talk about the big picture, about how these theories of individual behavior fit into a larger model of health and society.